So we'll proceed with our next talk, which is a session that's sponsored by Eli Lilly. Our speaker will be Dr. Omar Albanyan. Omar موجود؟ ممتاز. Dr. Omar is a section head of the chronic leukemia and myeloproliferative neoplasm and consultant in malignant hematology and blood and bone marrow transplant at King Faisal Specialist Hospital, Riyadh, Saudi Arabia. So Dr. Omar will be talking about navigating treatment options after BTKi failure in an evidence-based discussion. So please keep quiet, please. Hello, silence. Please.
Thank you very much, Prof. Askar. And thank you for the SSBMT member for giving me the chance and for Lilly sponsoring this talk. So I'll be talking about the navigating treatment options for CLL after Covalent BTKi inhibitor. So this is just the speaker disclosure and disclaimer. So at a glance, chronic lymphocytic leukemia is the most common leukemia in the Western world, accounting for approximately 20,000 cases per year, and accounting for approximately 30% of adult leukemia and approximately 1.2 of all leukemias that has been reported in the SEER database in 2025. Reported 5-year relative survival is around 89.3. It's a disease of elderly, so median age of diagnosis is 70. However, with all that, we know that the numbers are less incidence or age-wise also less in our population. The overall outcome has improved dramatically over the past decades with the addition of novel treatment. So this is the targeted that we've been working on or targeting in CLL. So most commonly is the BTK inhibitor. We have the ibrutinib, acalabrutinib, zanubrutinib, bertebrutinib, the BCL2. We have the venetoclax, the CD20 using the rituximab, obinutuzumab, the PI3K kinase inhibitor, the idelalisib with the duvelisib, and of course the CD19 for the liso-cel. Just showing the list with timeline of the agents that have been approved. So in the past was heavily chemotherapy focused in CLL. Now we've moved further and further away from using chemotherapy in patients with chronic lymphocytic leukemia. So what are the BTKi that are currently used in a treatment-naive patient? So we have the irreversible covalent inhibitor. We have the ibrutinib, the acalabrutinib approved after the ELEVATE-TN. We have the zanubrutinib that approved after the SEQUOIA trial. And then we have the irreversible covalent inhibitor in a fixed duration setting. So we're using the ibrutinib and venetoclax after the GLOW trial, and the option of using acalabrutinib, venetoclax plus minus obinutuzumab that was approved after the AMPLIFY trial. So this is all has been the covalent binding. They are reversible, as you can see on the right side. It is dependent on the C481 pocket for binding the BTKa to the cell. So it is covalent irreversible binding site. On the other hand, bertebrutinib is a reversible binding that is non-covalent and independent on the C481 pocket site. So it has a different mechanism of action than all the approved BTKi in the frontline setting. So in a preclinical studies, the pharmacokinetic profile of bertebrutinib maintained above 96% when using once a daily dose at 200 milligram. So that is the dose that they proceeded with. So moving to the clinical study that led to the approval of bertebrutinib and through the Saudi FDA is the Bruin CLL 321. It is the first randomized trial for second-line BTKa exposed versus chemotherapy. So if you've used bertebrutinib versus idelalisib and rituximab, or bendamustine rituximab per the investigator choice. So they've included all patients with CLL in the relapse setting with requirement of treatment as per the IWCLL criteria, and included all patients with a prior exposure to covalent BTKi inhibitor. They use some stratification. They use 200 milligram once daily versus the chemotherapy. But it's important to note that all patients who progressed on chemotherapy, they had the option to cross over to the pirtobrutinib arm. So they enrolled around 119 in both group. You can see that the median age is around 66 in the pirtobrutinib, 68 in the chemotherapy arm. The median line of therapy is 3 in both groups, however, reaching up to 13 and 11. All patients have been exposed to prior TKI. We'll go into more detail in the next slide. And the reason for discontinuation, almost 70% discontinued treatment due to disease progression. The others were either due to toxicity or side effect. Prior BCL2 exposure, so almost 50% of patients has been exposed to BCL2 prior to enrollment to this trial, whether in the chemotherapy or in the BTKi pirtobrutinib arm. They included the high-risk population, so around 50% or more than 50% either had 17B or TP53 mutations. Almost 93% and 80% had IGHV unmutated status, and large number, 72 versus and 59, had a complex karyotype. So go into more detail about the BTKi that the patient has been exposed to. So most patients were exposed to ibrutinib, almost 84 and 89%. Less common, 14 versus and 17 acalabrutinib, 8 and 6% zanubrutinib. Almost 17 or almost 20% of patients have been exposed to 2 prior BTKi before enrollment. As I said, 50 to 52% have been exposed to BCL2 inhibitor. So going to the response, so most patients, as you can see in this waterfall, most patients has been achieved a more than 50% greater reduction in the tumor burden. So the majority of patients have achieved a greater response, more than 50%. And looking at the progression-free survival, so with a median follow-up of 19.4 months for pirtobrutinib and 17.7 months for the chemotherapy arm, the median PFS was 14 months versus 8.7 months, so with a 5.3 difference in months-wise and hazard ratio of 0.54. And then looking at the median to the next treatment, and that was left to the investigator discretion to decide when to start the second line. You can see there is a median time is 24 months for the pirtobrutinib versus 10.9 months for the chemotherapy arm. Looking at the outcome, if the patient has been exposed or has not been exposed to venetoclax before enrollment, so if the patient has been previously exposed to venetoclax, you can see the PFS is slightly dropped. 8.3 in the chemotherapy arm versus 11.4 months in the pirtobrutinib arm, with almost 3 months difference. Still superior, but it is less than patient who was venetoclax or BCL2 naive. That is 10.4 versus 15.3 months. So overall survival did not show any significant difference in the overall survival. However, just to keep in mind that 75% of the patients who progressed in the chemotherapy arm already crossed over to the pirtobrutinib arm. Looking at the adverse event, so prior to the CLL-321, there was the Bruin phase 1-2 trial that also included almost 223. The side effects profile was comparable between 2 studies, similar to what you expect in a patient who has been exposed to BTKi. So we always have to keep in mind that BTKi exposed patients, they are at high risk of infection. So we have pneumonia, we have COVID, some GI toxicity, not included in the slides, but side effect of interest in BTKi are the hypertension, the atrial fibrillation, bleeding also has been reported, but it's in a very small percentage, around 3 to 4%. So more interesting with more knowledge with BTKi is understanding the mechanism of resistance and how does the mutation burden behave baseline, during treatment, and after treatment. So I'm including just 2, to me, is very interesting paper that looked at that. So this paper looked at the patient who were treated in the Bruin phase 1, phase 2 study. They looked at all patient baseline mutation burden, and then they assessed the mutation after treatment or progression with the pirtobrutinib. So looking at all those patients, so just to keep in mind that in that study, almost all patients was already exposed to BTKi. So the common mutation at baseline before enrollment was BTK mutation, around 43%, having TB53 mutation around 38, SF3B1 25, and the list goes on with less frequent. BCL2 mutation was present in 8%, but interestingly, all 19 patients who had the BCL2 mutation were exposed to BCL2 prior to enrollment in the study. So what happened after pirtobrutinib? So around 119 patients, or 119 mutation in a 54 patient cleared after being in the pirtobrutinib. Most importantly is the C481S has cleared. And the acquired mutation, there's around 138 mutation that was acquired after the exposure to the pirtobrutinib. So 44 on the BTKi, 24% in different mutation, 32% of the patient with progressive disease did not acquire any mutation. So here you can see the allelic frequency of the mutated gene. So you can see in the further left, the blue column reflects the cleared mutation. So the majority of the patients who were started with a 481S cleared after being treated with pirtobrutinib. However, there's developing a new mutation. So the most common mutation developed is the gatekeeper 474 in around 28 and 23 patients, and the L528W in around 14 patients. So recently in ASH, this is a very interesting paper that was reported by the Flair group. So they included in their analysis for the patient who've been receiving ibrutinib, rituximab, or either single R ibrutinib or ibrutinib venetoclax. So what they did is, so this is just showing the same thing, the mechanism of resistance and mutation. So what they did is they looked at the patient's baseline before enrollment in the study, and then 6 months, and they continued to collect sample every 6 months until the patient progressed. When the patient progressed, they will go back, analyze all the samples to understand the pattern of the mutation throughout the disease course. So they detect the mutation through two mechanisms. One, they've used the MI-seq for NGS. Second, they used the digital droplet PCR to detect the mutations. And in the PCR, they mainly looked for the 481S, the T474I, and the L528W, that the most common mutation we see with BTKi patients. So in total, the analyzed sample, around 136 patients progressed in those three arms. 9 of the, so 136 136 progressed, 29 mutation were detected, 9 through the MI-seq and 20 through the PCR. So interestingly, looking at the in the bars on the left side of the slide, you can see that patient who received ibrutinib, rituximab, and progressed, around 24% of those patients did develop mutation. Patient who's been exposed to only ibrutinib, around 18% of those who progressed developed the BTK mutation. But interestingly, for patients receiving both ibrutinib and venetoclax, none of the progressed patients developed any BTK mutation. So looking at the types of mutation, they noted, so the majority of the patient had more than just one mutation. Around 18 out of 29 had more than one mutation. The most common mutation is the C481, which is creating the resistance to the ibrutinib in this arm. No mutation were detected at baseline before enrollment in the study. The L528 and the 474 were never a sole mutation. So we're always accompanied by the 481S. And last, that's not clear here, is that interestingly, all patients who develop mutation were IGHV unmutated. So this is just tells you about the high risk, understanding more of high risk about the IGHV status. So just looking at the 2-time course, this is the most fascinating things about this study. So this is an example of increasing clone size until disease progression. So you can see the background yellow indicate the patient is currently on ibrutinib. The dotted gray is the disease burden. So as the ibrutinib starts, the disease burden drops down. And you can see the BTK, the mutation burden is increasing as the disease burden increases. And also you can notice that the BTK mutation start to increase before the disease progression, and they continue throughout. In the second slide, I'm just showing that example of decreasing clone size after cessation of treatment. So again, background, the yellow is the treatment with ibrutinib and rituximab. The gray dotted line is the response. So the patient start to have increase in the mutation burden, increase in the disease. Ibrutinib stop around the 70 months timeline. But what is interesting, as the ibrutinib was discontinued, you can see that the tumor burden is growing down. So showing selective pressure of ibrutinib, explaining the drop in the mutation burden. Just in summary for the study, there's no BTK mutation were found at baseline. 21% of the patients who progressed had BTK mutation at one of the three C481, T474, or L528 residue. When treatment stopped prior to disease progression, the allelic burden of BTK mutation started to decrease. Median time of first detectable mutation was around 67 months, and from the first detectable to disease progression was around 7 months, and no BTK mutation were in IV patients. And with that, I will conclude my talk. Thank you very much.
Thank you, Omar, for finishing on time. You saved us a few minutes. Thanks. One question, please.
Yes, please.
So how do you see the compliance with the bertobrutinib versus others? Now it's considered a second-line relapse refractory after first-generation BTKi inhibitors. I mean, we have the two options: the fixed duration, the bertobrutinib. And if you could comment on the compliance and
Sure, yeah. A very, very good question, and it's a very tricky position on when it comes with the options available and which one would you prefer. So in general, bertobrutinib, in my experience, I've seen it to be a bit like a favorable drug when it comes to the side effect profile. It's easier compared to other medications when it's used as a once daily. It's easier when it comes with other BCL2 inhibitor when it comes to the need for monitoring and ramp up dosing and TLS prophylaxis and concern. So I have not encountered a major side effect that led to the discontinuation. The only thing that I always keep in mind, and it's not only for bertobrutinib but on all CLL and more with BTKi inhibitor, is generally those patients at high risk of infection. So the concern is usually when those patients are developing infection, whether to continue or to interrupt the treatment.
Great. Okay, for the sake of time, we need to move on. Thank you, Dr. Omar.
Thank you very much.
Again. And I would like to invite